I'm very delighted to be here. In fact, I was pleasantly surprised to actually get into the country after Brexit. When I saw the heavy rain this morning, I fully expected a thunderbolt of lightning to emanate from the EU HQ, but here we are. Peter asked me if I would talk about the impact of optimal care of upper airway inflammation on lower airways. And I sort of feel I'm teaching my grandmother to suck eggs, as we would say in England, because I'm speaking to an extremely well-informed audience who probably know better than I do most of the work that I'm going to present. And I was reflecting, listening to Jean, that in fact practically all that I'm going to say is perhaps overtaken by some of these wonderful programs such as been done in Finland, where a public health initiative has actually made and will make a profound effect, much greater than perhaps surgeons will ever do. In fact, if you go to a medical school interview and you say that when asked why you want to do medicine, you say, I want to save lives, then the traditional answer is then you should go into public health, because actually that is probably where it really makes the difference. However, having said all of that, we do know that there is an association, as commented by Niels Mergind, and we are talking about an interaction between various parts of the respiratory tract. And of course, we are dreadful collectors of other people's ideas in rhinology, and most of our medical treatments have actually started life in the chest. It's hardly surprising, given the way in which the upper respiratory tract provides protection to the lower respiratory tract, that disease in that area can be seen to trigger problems lower down. And this concept of united airways has been around for probably about 3 or 4 decades, if not longer. And I think probably the best embodiment of this was the ARIA exercise, which was masterminded by Jean Bousquet and Paul van Kouwenberg and others, which really brought together many strands to look at this very complex interrelationship between the various parts of the upper respiratory tract. Peter has also talked about this continuum, both physiologically and particularly pathologically, in a very nice paper published some years ago, but has obviously expanded on that in his more recent research. But for a simple-minded surgeon, I still find a diagram like this quite useful, because it reminds us of this interplay between the various diseases. I won't say very much about the common cold or COPD, because there's relatively little in the literature to support improvement, although again the public health study has shown some interesting improvements in COPD from reduction of allergy in Finland. Of course, there are many possible mechanisms, and perhaps part of the discussion tomorrow will be about how we actually approach the understanding of what this interplay actually means. There are many possible ways in which problems in the nose can affect the lower respiratory tract, and the way in which that lower respiratory tract will respond. And one can make rather simplistic lists of the similarities and differences between the upper respiratory tract, but I think on balance there are more similarities and overlap between the areas, both in their anatomy and physiology, than differences. And the more we know about the way in which remodeling occurs in the upper respiratory tract, the more we understand that we're really looking at manifestations of a similar process. I think everybody would accept now that there is very much an interplay between allergic rhinitis and the risk for the development of asthma. These are old studies, but I don't think they necessarily are devalued because they're old studies. They were landmark studies demonstrating the importance of allergic rhinitis in infancy, increasing the risk of asthma, and indeed the same being shown in adults, comparing students with allergic with rhinitis developing asthma against those who did not. And most of you will recall the landmark study by Lennart and Jean Busquet's group, demonstrating again this relationship between perennial rhinitis as a risk factor independently for asthma. So there are quite a lot of studies in the literature which have been discussed in other articles, showing different ranges of percentage relationships between allergic and non-allergic rhinitis and the development of asthma. And I think, once again, a Scandinavian study from Copenhagen showing a 300 times risk of asthma in patients who have allergic rhinitis as compared to normals. I mean, really punches home the message. So if one summarizes the epidemiological evidence for one airway or united airway concept, we can say that there is good level 1 evidence for this relationship, both with allergic and non-allergic rhinitis. And similarly, we can see, particularly when conducting challenges either in the nose or in the chest, that responses can be demonstrated in other areas of the respiratory tract. Okay, so what is optimal treatment? I think therein lies quite a big problem. At least in the treatment of allergic rhinitis, one has grade A recommendations based on level 1 studies in order to support the use of various treatments. And back in the day, we produced a rather nice, colourful, stepwise approach to the treatment of allergic rhinitis, again, based on severity, as opposed to particular definition of what is, of course, quite a heterogeneous group. This has been superseded to some extent by the Practal recommendations, which don't project quite so well, but essentially have the same message, in which one is looking at progression based on severity. Now, if we look in the literature then at treatment as opposed to other strategies as have been used in Finland, there are quite a few studies in the literature looking at the effects of treating rhinitis on the course of asthma. And this just lists some of the medications, in fact, many of those medications that featured in the stepwise management. Good levels of evidence, 14 studies for antihistamines, chromalin, intranasal corticosteroids, immunotherapy, leukotriene modifiers, and of course, more recently, anti-IgE. And if we look at some of these studies, some of them produced in the early years 2002 and 4, we can see that the use of these medications, be it intranasal corticosteroids or antihistamines, can be shown to reduce the number of emergency room visits. These are quite large cohort studies, nearly 5,000 in the ADAM study, reduce the hospitalization of patients with asthma, 13,000 in the Crystal Peter study, and a reduction of both ER and hospitalization in the Corin study. And this slide just emphasizes that distinction with a 61% fewer hospitalizations in the treated patients as opposed to the patients who did not receive treatment for their allergic rhinitis. So these are quite compelling studies that suggest a very important reason for treating allergic rhinitis in our asthma patients. Of course, the advent of the biologics, it's the great white hope now, isn't it? We've moved seamlessly on to a new age, but it's not such a new age. The pivotal SOLAR study, again done by Jean and his team, showed that omalizumab is effective in both seasonal and perennial rhinitis and in asthma. Now, of course, if we sort of look at the converse side, in this particular review article, it was pointed out that there are 1 or 2 studies that have looked at asthma treatment improving the course of rhinitis, though it's interesting that they are rather fewer on the ground than the other way around. But certainly there is some evidence to support that, in this case using inhaled budesonide. I think these studies, looking at what is essentially a change in the natural history of the disease, are actually the most interesting, because here we see the use of immunotherapy, be it subcutaneous or sublingual, actually having a very profound effect on young people with seasonal allergic rhinitis receiving immunotherapy, which actually prevents the progression to asthma. And that really is something of considerable importance. These, again, are landmark studies done by Moller and Novembre in 2002 and 2004. And these, I think, are really very important studies which have made quite an impact, certainly in many parts of Europe. This meta-analysis was done a few years later, looking at 25 studies, and again demonstrating that immunotherapy significantly reduces asthma severity, and of course, again emphasizing the fact that sublingual immunotherapy is a safe alternative to subcutaneous routes. And this, of course, inevitably has a very important impact on healthcare costs, as was outlined by Halpern and colleagues. So again, very good reasons for treating allergic rhinitis if one wants to improve not just the nose but the lungs. Of course, if we move on to chronic rhinosinusitis, things become a little bit more murky. We know from the Galen study that about 11% of the population in certain parts of Europe suffer from CRS, and although it's a very simplistic diagram, it clearly encapsulates the complexity that we now understand comprises chronic rhinosinusitis in all its many forms. Klaus showed you the cluster analysis that was done on some of the patients undergoing surgery in the Galen cohort, and again emphasized this very large number of endotypes that can be defined from a population of patients who, on the face of it, are all just communal garden patients with chronic nasal symptoms. And we know that from the literature, there are just an immense number of comorbidities and conditions which may have a bearing on the etiology or the subsequent development of disease which affect both the nose and the chest. Because of that, in the most recent edition of EPOS, we did devote a separate chapter to this interrelationship. And Peter has already shown us from this article, looking at patients who we fail to control, and as he pointed out, that may be 30 or 40% of the patients that we see, that the role of systemic disease or global airway disease can be a very important factor indeed in leading to that lack of control in the upper airways. So I think, again, the evidence that there is interrelationship is really not up for debate. We would all accept that there is this interrelationship which is extremely important. It may be especially important in particular subgroups, such as the difficult-to-treat asthma, the late-onset patient, or those who have aspirin sensitivity. But I also think there's a big message to be put out to particularly our ENT colleagues that there are a large number of patients out there who, on the face of it, do not appear to have asthma, but if you even look very slightly and below the surface and do some peak flow measurements and talk to them carefully, you will find that a very significant number of our patients with CRS indeed have mild forms of respiratory disease, in particular asthma. The percentages vary in the literature when you look at the association between CRS with nasal polyps and other diseases, but again, we know for sure that those who have aspirin-sensitive asthma, conditions such as eosinophilic or allergic fungal sinusitis will often affect the chest and other more systemic diseases such as Churg-Strauss syndrome will all have a very significant percentage of patients with nasal polyps. So we know that if we look at CT changes, they, in patients who have CRS, that they will be greater, more severe in patients who are asthma, and that there is a correlation between the asthma severity and these changes, although not everybody has actually demonstrated that. I've just put a few of the studies that have shown a positive relationship. And as I said, in the Galen study, it was clear that was a strong association in the patients who had polyps with asthma as compared to the control group. So as again, I'm sort of preaching to the converted when I say look at the chest, but it is a message that we have to keep putting across to our colleagues. Those changes on the CT scan can also be correlated with other measures such as sputum eosinophilia and other lower respiratory tract function tests. But as I said, some people have not demonstrated, such as Dr. Ragab in the States, any correlation between rhinosinusitis and asthma severity. So there is some variation again in the literature. Now, whilst it was a little bit easier to define what was optimal treatment in allergic rhinitis, we do have a few problems when it comes to chronic rhinosinusitis. Klaus was rather scathing about the tables and algorithms in EPOS, and well, he might be, but it's always a pragmatic approach to what is available at the time when you review these things. And certainly when we looked at the literature in 2012 and in the subsequent ICOR consensus document produced by the Americans, very similar tables are produced showing the levels of recommendation for some of the common medications that are available to us. Since the table was published in 2012, you can see that there are now some very good randomized controlled trials for the other medications, aspirin desensitization and the anti-IgE, etc., which have subsequently been published. But if we look at the use of antibiotics in the treatment of CRS, obviously this is predicated on not the antibacterial activity, but its potential for immune modulation in a range of different ways. And again, this followed on from the work of and observations of Kudo and colleagues in Japan in the early 1980s, showing dramatic improvement and survival of patients with diffuse panbronchiolitis when they were treated with long-term macrolide antibiotics. And on the basis of this, the use of the macrolides was extended to the treatment of chronic rhinosinusitis. It was also demonstrated from those studies that there needed to be a fairly prolonged course for the macrolides to actually have their immune modulatory effect. And again, on this basis, courses of anything between 3 months and a year have been used. But unfortunately, most of those studies have been open studies without any randomization and indeed without any placebo arms. We did randomize patients between surgery and a medical arm which comprised 3 months of erythromycin some years ago. And whilst the main focus was on what was going on in the nose with a variety of outcomes, we did look at the chest in half of the patients who happened to also have asthma. And this included looking at the usual clinical outcomes of medication use, hospitalization, and overall asthma score, but also at some of the objective measures of lung function. And it was quite interesting to see that both the upper and the lower respiratory tracts overall improved in both arms of the study. It would appear that the more clinically based outcomes, such as the use of bronchodilators, systemic corticosteroids, and hospitalizations, etc., improved in both of the groups, both medical and surgical. But in the patients that were receiving the erythromycin for 3 months, we can see that in addition to the chest score, the objective measures of lung function improved much more in the medically treated group as compared to the surgical treated group. And this is just a comparison here between the medical and surgical groups, looking at the percentage decrease of expired nitric oxide in the chest and the increase in FEV1, showing benefit was greatest in the medical arm. Now here's the algorithm much disliked by Klaus. The problem is, as everybody has told us this morning, it would be wonderful to have a biomarker, but we don't have one at the moment that is reliable. Of course, once we have, the world will be our oyster. But unfortunately, at the moment, we have to use a scattergun approach, and we tend to rely on severity as our determinant of that approach. And we also know that a significant number of patients, despite our best intentions, will not get better with medication and do end up having surgery. Of course, once you let the surgeons in, then things get very untidy in these studies. We all know from many publications that asthma is regarded as a poor prognostic sign in the treatment of patients, particularly surgically, although I have to say that the literature is very mixed. Some people, such as Kennedy, have shown that it is only of importance in the more severe cases. Others have demonstrated a no effect, whereas there have been several other studies suggesting that it is actually a bad prognostic sign. However, there's also been debate in the early literature as to whether if you operate on patients with CRS with nasal polyps, you might even provoke the onset of asthma. I think that tends to have been a somewhat anecdotal reporting, and it's not something that's really been observed to any degree since, but it is quite an interesting footnote. Certainly an improvement in asthma has been recognized since the 1800s, and even with simple polypectomy done in the 1980s, there are papers describing improvement in the use of medication for asthma after the surgery had been undertaken. We did an open study looking at a cohort prospectively of patients with asthma undergoing endoscopic surgery over a year period, and again showed that there was an improvement in overall asthma control and use of medication, with some improvement in about a third of the patients in their objective lung function tests. There wasn't a particular difference between patients with and without nasal polyps, and we didn't observe any worsening of the asthma, but of course, like the REGAB study, unfortunately there was no control arm. And that's true, unfortunately, of most of the studies that are published in the literature when it comes to surgery. Most of them report a positive impact of endoscopic surgery on asthma in patients with CRS, particularly those with nasal polyps, both in terms of medication, hospitalization, and objective lung function. But if you look at the list there, you can see we're talking really rather small numbers of patients, and certainly no placebo or control arm, and usually quite short follow-up. This study, which came out in the 1990s, was based on a cohort of 120 patients, only 30 of whom were asthmatic. It did have the virtue of having quite long follow-up on the patients, and there was improvement in what we might call the subjective outcomes, but unfortunately there were no objective tests of lung function done in this study. This is a somewhat better constructed study from 2010 from Greece, looking at 94 patients over a one-year follow-up, which they got 86 to the end of, and again showing some improvement in their overall symptoms and medication use, and also demonstrating improvement in objective tests such as FVC, FEV1, and peak flow. There are even one or two studies looking at children. Obviously, endoscopic surgery for children with CRS is rather less common, but this study from Scott Manning and colleagues in Iowa looked at a very tiny group, hopelessly underpowered, but 14 patients who were severely asthmatic, children between 3 and 13. And again demonstrating that there was improvement in the subjective outcomes, but no change in pulmonary function tests. And of course, surgeons never agree completely with one another, so there are always a couple of studies which suggest that none of this is true, but again, very, very small numbers, 20 and 34, really showing no effect, but I think we might question the numbers of patients. So these are all studies done in tertiary referral units. Are they the real world? Does the real world matter? Yes, it probably does. And we tried to look at that some years ago on over 3,000 patients being operated on in the UK, throughout the UK, lots of different surgeons, different levels of surgeons in many different departments, and we were able, in collaboration with the Royal College of Surgeons, to follow up the patients for 5 years. Now, we weren't directly looking at the lower respiratory tract. Our focus was obviously to see whether their nasal symptoms got better at that time, and indeed they did. Patients improved, and that improvement was maintained from 3 months to the end of the 5-year study, irrespective of whether they had polyps or not. But what is perhaps a little more interesting is Claire Hopkins, who's been associated with the study for a long time, went back and looked at the data and divided the patients up into those who had had their surgery within a year of presentation, and those who had had it after 5 years, and a middle group between the two. And this showed that the percentage change from baseline was greater in the early group. Now, Klaus raised this. Should we actually be defining patients on whom we should operate earlier? And what is interesting in this group is that you see that the frequency with which asthma is found is much greater in the late surgical group than the early one. Now, it's difficult to know how to interpret it, whether it's cause and effect. But another study which Claire did, looking at a big group of patients retrospectively and looking at the utilization of healthcare, showed that in those patients who had early surgery and no asthma, was significant underutilization of healthcare as compared to those who waited longer for their surgery and subsequently developed asthma. Now, again, you may interpret that in different ways, but it could imply that delay of surgery is associated with increased risk of asthma. And if you compare the two lines of early and late cohorts, if you look at the time of diagnosis when approximately the same number of patients had asthma at diagnosis, about 21 or 26%, and then look what happens after surgery, you can see that the onset of asthma actually declines from the point when the patients undergo surgery. So, that's all very interesting, but why should it happen? Well, we can't even decide how surgery works in the nose. We have a long list of things which might be happening, such as reduction of IL-5-ectomy, inflammatory loads, stopping remodeling, preventing the biofilms and the microbiomes from doing their worst, etc. Or are we just providing a space into which the medication works? Well, if we don't know how it's working in the nose, we know even less about how it's working in the chest, but the most likelihood is going to be some reduction in systemic inflammation modulated from the nose. So finally, this systemic review, which followed another one that was done in 2013, looked at the medication as well as the surgical trials that have been published and showed that there was some evidence in the literature for improvement in subjective, not always objective change, but usually a decrease in medication as a result of these medications, montelukast, omalizumab and erythromycin, and similarly with endoscopic surgery. But as ever is the case, these trials are marred by small numbers, varying outcomes, and the lack, certainly with the surgical trials, of randomized controlled trials. So I think we can conclude that there is definitely an impact on the chest if you do things to the nose, and I think on balance, it's a positive one. Quality of life seems to be improved, and healthcare costs may go down. How it happens, I would be very interested to hear your views. And as always, at the end of these talks, we always say there is a need for better trials in order to shed light on a fascinating area. Thank you very much.